Hey guys, how's it going? I hope you guys are having a peaceful week leading into this holiday. Can you believe that it's Thanksgiving next week? I cannot believe that we're already here in the holiday season. It has snuck up on me again. How does that happen? How does that happen? My daughter, who is now an adult, those of you who've hung out with me before know that. She's like of that same belief that when you're in adulthood, all of a sudden time just flies by. When you're like a teenager, everything is endless. It's like school year is never ending, and summertime feels like an eternity in all the good ways. But now it's like you snap your fingers and it's the end of a year, or it's the end of a month. Those of us in medical billing, I feel like that's the norm. So hello, if you are new here, welcome. My name is Jasmine. I'm very, very happy to have you here in this space. This is Inlera University. We are on our Medical Billers Network Live. This is our Thursday home, the place where we hang out on Thursdays. I'm noticing that I probably messed up our overlay here. There we go. That's Medical Billers Network Live. So we are here every Thursday. This is 2 p.m. Today we are kicking off our discussion about denials. So it is going to be like a little mini series if you, if you are brand new to denial management or working on denial resolution, this will be a great conversation for you to be a part of. My folks who are experienced, please weigh in, because those of you who are in this world know that we all have our unique scenarios, and your perspective is huge for everyone else on the other side of the world, the country, that might have your same situation, your same scenario that I maybe do not have. So I really would love to have you guys join in. But before we do that, when you get in this space, say hello. Let me know that you're here, like Osama did here. Hi, Osama. Good to see you, friend. Welcome back. Welcome back. Okay. And I'm going to quickly prompt you on the question of the day that I'm looking at. What's your most common denial? This is medical billing. You are all going to find your own unique scenarios in all different corners of specialties and states with carriers that will run the gamut of variety, right? You will have a mass variety of scenarios or situations that might be different than what I see. So as I mentioned earlier, if you have experience in a particular specialty or see a certain type of denial, please let us know what you see. Christy celebrating your image there. Yeah, we get a kick out of Nicole's humor. She's the bomb.com. Let me pop up real fast. I missed some comments here. Okay, so real quick, we've got a couple of updates. So Ashley says COB. We'll talk about that a little bit today. Christy says eligibility. Ooh, yeah. Say, hey, Trudy, good to see you. Another North Carolinian in the house. I love it. So good afternoon, Incy Worker. Hello. It's been a little while. It's good to see you, friend. Welcome back. Welcome back. All right. So know that what I talk about today and what we're going to be talking about today, they might be unique scenarios that you might have a better perspective or a different perspective than what I say. So please feel free. This goes with anything that we talk about on this channel. This is not about Jasmine. It's not just highlighting Jasmine and me yammering on. I want to get everybody's input because we are a community here. All right. You guys know this. If you've been here before, that is my motto. My battle cry is we can only do this together. We can only make these changes together. So I want to quickly open up something on my screen so that I can remember where I'm supposed to go in our next chat here. Okay, there we go. All right, so I talked about this already, that we are going into kind of a mini series this week, and next week is Thanksgiving. I will pop on next week to chat with you guys. We won't talk denials, but the following week we will continue this conversation about denials. So if you, over the next few days, gather some more information, or if you're looking at this video on the replay, please feel free to make comments and we'll revisit it, and we'll take a look at those comments and see if we can address some of your questions, issues, concerns. So those of you who have hung out these last few weeks, we've talked a lot about data capture, front end reception, front end of the revenue cycle, right? These types of processes that we've discussed, and essentially the challenges that we're all facing, the area of discussion these last few weeks has really lend itself to this to really be useful in this conversation that we're having today, because still data capture related denials takes the place for number one, which means the way that you can help alleviate what you are experiencing with these denials is by improving upon your understanding of the front end and how well it should function, and also preventing those denials, right? So the best and first line of defense is always prevention, right? Is always prevention. So we are looking to try to prevent these things from happening in the first place. Now, some of us do not have control over that. Some of us do not have access to the front end to be able to make those changes. So I completely know and understand where you might be struggling with making an impact on the front end. All right. So first thing I'm going to make a mention of for you guys who don't have control is find out whether or not there's someone in your department, organization that can have an impact. All right. So if you are understanding the types of denials that you have, an example like Christy's mentioned for eligibility, is there a way that someone in your department could communicate with the powers that be on the front end to help integrate some useful tool that checks eligibility before the patients are even seen in the practice? All right. So that's one example of ways that we can leverage our tools, our resources to encourage the practice to function better and hopefully result in preventing these denials in the first place. So when we know what our denials are, we can have a better path to resolve them. So the next most important thing is to become familiar with, to wrap your head around the denials that you are seeing most often. So we're going to talk a little bit more about denial management in our next conversation, because denial management is more gathering the data and trying to make use of the data so you can create a better strategy. That's a little different than resolution, really. And I say denial management really should come before resolution, right? We should get ourselves organized, know exactly where to head so we can create a proper plan of action. All right. But today we're chatting briefly about denials and denial resolution. We're going to touch on that, and we're going to tap into management and then revisit more ingrained resolution conversations. All right. So if you are first time in a practice and you are trying to work on denials, the thing that I would absolutely suggest that you do right away is make sure that your software is not just blanket writing off. Yeah, just writing off all of the denials without noticing what type of denials are okay to write off. For example, a CO45, we know CO45, as long as the practice is contracted with the carrier, that is an anticipated denial. We do not need to work those denials. Okay. We don't need to do anything with those denials. Those denials are expected or anticipated, and that would get written off just fine. However, other denials that we know need potentially some kind of recourse, medical documentation related, or what we just talked about, things related to denial capture that are challenges with patients' setup in your software on the claim forms, right? Those are all things that we don't want our software doing any sort of automatic blanket write-offs for those particular COs. All right. And I say that because I see a lot of systems that have really both ends of the spectrum. First, really severe writing off of all things CO because it says contract obligation or contractual obligation. The software has been told or a rule has been set that says when you see that a CO, it's a part of the contract, we need to write it off. And that doesn't allow us as billers to be effective at what we do, right? To be able to fight for the claims to be reimbursed. So it's important that you are clear about this being the severe type of CO not being the thing that we want utilized in the department. And then on the other side of it, you don't want it to be the rule to be either not implemented at all or too light, because things like CO45, We don't need a CO45. We don't need other types of anticipated denials that are going to come in. For example, the prompt pay discount, CO44, where we know that we're accepting payments from companies like Zealous or folks that are reimbursing us and reducing our payments down slightly because we have elected to receive those payments faster. That doesn't require us to do anything as billers to fight for additional compensation because we've agreed to that. All right. So it's super important to understand that our system setup is going to make or break how effective we can be and how clean our denial process can be, because so many. Hi, Belinda. Good to see you. Good to see you. Welcome back. So many people try to dive right into denials without first evaluating whether things are set up correctly. And they realize they've got a mountain of denials and they're cleaning up things like CO45s or things that we know are going to be write-offs that we don't need to acknowledge. And it's a waste of time and resources for you to be thumbing through these denials and not needing to do anything with them. Okay. All right. So next thing, when it comes to denial management, we're going to talk about this a little bit more. You really want to understand what your top denials are for your practice and become very, very familiar with those denials and what your path to resolution is. And we'll talk more about how to organize yourself in that way in our next chat. However, in this discussion, what I really want you to be thinking about is how can I become familiar with the denials that I see, and what are the steps that I am taking that are resulting in the best results, right? So if we know that, for example, you have an insurance carrier situation where your authorizations are getting approved slower than your claims. So you are sending claims out before the insurance company has updated their records with an authorization. So you have claims denying for lack of authorization, and you have to go back through and request the insurance to reprocess those claims. If you know that is a scenario that you see on a very regular basis, you're going to, number one, you're going to figure out what to do for the ones that have already gone out the door. And then you're going to create a very clear path of how to resolve those for yourself and anybody else that might be supporting you or helping you. And then you're going to try to prevent that from happening, right? So go to whomever, whether it's you or an administrator in the practice or in the billing company, that can help you prevent claims from going out faster than the authorizations are getting approved. And sometimes that's as simple as delaying claims for a particular plan type or insurance type. All right. Meaning you won't send those claims as quickly as you might be sending all of your other claims. So if you are on same day adjudication, like I have seen practices that have same day submission, if the encounter happens in the morning and the provider closes it, the claims go out in the afternoon. That's cool. But if you just submitted an authorization that same morning for a patient's service, you're probably not going to get the proper outcome for a claim if you just waited a couple of days and sent that same claim out the door. Okay. All right. So speaking very broadly, just to give you some good examples there of what I mean when it comes to creating a path for your own resolution, because you guys are going to be the best resource for creating a denial resolution workflow for yourself or your business, if you're creating one for a business or a department. All right. Because your situations are going to be unique, but you can use these examples and what we're talking about today to help apply a better strategy. All right. So with that said, I want to quickly talk a little bit about, zoom out just a little bit about these codes. We've touched on this in previous videos, but I want to make sure my friends that are brand new or joining us for the first time in these types of discussions around denials, I want to ensure that you all are clear on exactly what resources we recommend for looking into denials and denial codes, because there are software out there that will send you kind of incomplete reasoning definitions for your reason codes or your denial, the codes that we're receiving for our claims. And I'm going to walk you through. I'm sorry, while I'm doing this, I'm trying to dock in. I'm not very good at that. Okay, here we go. All right, so this is the site I've mentioned in the past. This is X12. They are the resource that they will be the ones that publish the record for the denial and remark codes. So we've got two different types of, sorry, I'm realizing I'm trying to modify the wrong screen. Okay, we've got two different types of codes here, really. So the remark codes is something else. I want to zoom out. Here we go. Yeah, and show you guys first our claim adjustment reason code groups. All right. So my friends who are brand new to the world of medical billing, when we receive our remits, which is our EOBs or electronic remittance advice, remittances are the details about the payment, right? Those are usually accompanying the deposit that you're receiving. So you're getting it the same day as the deposit in some electronic form, or it's accompanying a physical check. All right. On these documents, whether they come electronically or on paper in the mail, snail mail, you will see codes at the bottom of them. All right. And I'll show some other examples of those codes of an EOB at a different date. You could look some of our other videos that have EOB examples as well. But, oh, I'm so sorry. I was trying to expand this on my side. Okay. However, when we see these, we've got really a few different types of groups. So the primary codes that we see are what are called claim adjustment reason codes. All right. These codes are going to be typically right against the line item of the denial, meaning the line that was not paid by the insurance carrier. You will see a code next to that 0, right? And there's typically a column there that says something like claim adjustment reason code, or for short, it's going to say CARC. All right. So these codes they do come from a resource, and they are public resource. One of the reasons why this ANSI, which is the standardization of our electronic world being leveraged in healthcare, this is born from ANSI. The ANSI coding has done something for us that's great, which is it creates a lot of standards in the way that we receive our denials or the reason for the denials. Okay. Now, the truth is that these codes, the adjustment reason codes, are sometimes not leveraged in the best way, because these systems are really, they're moving quickly, and most of them are happening through rules that are set up at the insurance company clearinghouse or in their adjudication systems, okay, which is their claims processing systems. So when they see the claim and they decide it's not proper for payment, sometimes they use a very vague claim adjustment reason code, okay? And that is when we will want to leverage what are called remittance advice remark codes. Both are available on your remittance or your EOB. So when we talk about denials, we usually are thinking about these claim adjustment reason codes, the things that are COs and PRs that we see most often, or even the OAs. However, what you're also going to want to look at for clarity are your remittance advice remark codes. These are additional comment codes that provide more information about the primary claim adjustment reason code. All right. There are a lot of general codes that are out there. My friends who have been in billing for a long time know what I'm referring to, like the notorious CO16, the claim lacks information. Was it claim or service lacks information needed for adjudication? Like those kinds of denials that we receive, they're just so vague, and they could mean a lot of different things depending upon the specialty and the state that you're in. So it's important to understand that you are looking for both the claim adjustment reason codes, and the remittance advice remark codes. Most people are not paying attention to the remittance advice remark codes, and it gives us a lot more information. And I say most people, sometimes the software only captures, if you are working from a denial queue, sometimes your denial queue only captures the primary claim adjustment reason code and does not reflect the remittance advice remark code. And so you go out to make your phone call, to do all this extra rigmarole, and you had right on the EOB, if you pulled up the EOB or the remittance itself and took a look at the EOB, you might have plenty of information here from your remittance advice remark code. All right. So if your system, for whatever reason, the remittance that you're looking at or the paper EOB does not have the detail of the remark code, you can come to this software, this resource, and search for it. It has the entire list here, the entire resource available. It doesn't give you a pathway to resolve it by any means, but the information or the definition is present. Okay. So quickly talking about the groups here, just to talk about a couple of really important ones to know the differences between CO. Typically means that there's some sort of contractual indicator that is preventing the claim from being paid and causing it to deny or causing it to reduce for any variety of reasons, including a CO45, which is reducing it because you have a contract. Now, a PR is the second most common group code that we will see on the ERAs. And the PR just very simply means that they are determining that this particular service, instead of it being written off, it's going to patient responsibility. Now, it doesn't mean that you should just drop it to patient and call it a day. No, we will put it to patient responsibility if you don't have, let's say, the right insurance information on file, or if you don't have an authorization on, a referral on file, it's going to drop it to patient. And if your patient did in fact bring that referral, or you know that you received that referral, you could very well go ahead and appeal for payment. So just because it has PR doesn't mean you should ignore it, but it is important to know that there are some PR denials that you'll get for things like eligibility that are ones that you can resolve, okay? So we're saying a little high level here at the very front end of this chat, because I want to just make sure that I cover all of the stages that you guys might be in. So, sorry, I keep trying to move my screens around. Okay, yeah. So as we're here underneath the details here, you'll notice that it goes in numerical order. So you could type in the code that you're looking for if you don't have reference to it. Now, a lot of them reference these additional pieces here. This is very simply stating that there's some ANSI loop, basically electronic loop, that is telling you that it's present. You don't have to pay any attention to this guy after that. Typically, that first main section here is the one that's going to be the most useful for you. Okay. All right. So when we're looking at this type of system, so if I go to like CO16, for example, and it says claim lacks information, claim or service lacks information or has submission billing errors, this could mean a lot of things. So as I said, you're going to want to then refer to your remittance advice remark codes, because what this could mean is that you have something wrong with the coding that's present on the claim. It could mean that you did not obtain an authorization or send a referral in. There's all kinds of denials that we see with CO16 because it's so vague, right? It could mean that there's an operative report that's needed sometimes they use the wrong code that communicates that an operative report wasn't present. All right. So what you're going to, this is typically some of the things that we might see for operative reports down here as well. So what you're going to want to do is pop over to that remark, the remittance codes. Sometimes it's not on the line, and you're going to see it at the bottom of the EOB, and you'll see some additional codes. And how do you know if they are remittance advice remark codes? The way that you will know is these are all of our claim adjustment codes. They will always have these 2 digits ahead of them, okay? When it comes to remark codes, they typically have a singular digit See that? A singular digit. So it's either an M and sometimes an MA and sometimes an N as in Nancy. Okay? So those are the most common ones. And you see here, it just has a lot more detail about specific information, right? Missing, incomplete, ordering provider address, right? It's giving us more specific information about the reason for the denial itself. Okay. So I want to just make sure that you guys are looking into both your remark codes and, your reason codes and your remark codes, because these comment codes can give you the exact pathway to resolving it. So sometimes we think too watered down and we're like, oh, we just see these CO272s, which is services are not being provided by network or primary care providers, but perhaps it says something a lot more. Perhaps you have a little bit more detail about the specialty or specialist not being in that patient's network, right? So just thinking about that, it's the kind of general topic there, and I'm going to try to close out of this. I wish I had a better workflow for closing out of this. There we go. All right. Okay. So when we have that reference document, and what I can do is put those links in the, actually I can put them in the chat for you guys right now, I think. When you have the reference for the claim remark and adjustment codes, what it helps you do is decide what needs to take place for the steps to resolve your claims, because your claim denials, because what I tell you right now, if you have something like a vague denial, like a CO16, and you're in a specialty where there is a very clear line of explanation that's showing up under your reason code, your solution or your way to resolve those denials is going to be completely different than someone else in a different specialty. Okay. All right. So here's what I want to quickly go over, just a couple of some of these top denials here. So my friends who are, well, let's talk about some more anticipated denials first, because we get a lot of these questions in comments from time to time. I mentioned already CO44, your prompt pay discount. Oftentimes practices will receive fax requests requesting it. Let's say if a doctor is out of network with a plan, they might request that you reduce down the liability for that particular patient's out of network claim, and you sign off on that, you send it in, and you now have accepted a reduced amount for your claim to be paid faster. That's typically what that message communicates. When that happens, they will most often indicate that you've taken this kinds of discount with a CO44. And that is like our Zealous payment system, where Zealous also is an electronic method of payment. They either pay you by those virtual credit cards, or you can pay for direct deposits. In both scenarios, they are a third party and receive compensation for their services based on the fee that they take. All right. And because of that, because they are speeding up your payment process, not waiting for a check and your administrative burden of depositing that check, they also apply a CO44. CO44s are not something that you need to concern yourself with. All right. You don't need to you don't need to work on appealing those. They need to write those off because they are typically assumed denials. Now, if your practice is like, we don't want to take those reductions and whatever, then you need to deal with who is signing off on those things or who signed you up for Zealous. Whole other discussion. Okay. All right. Same thing we talked about CO45s. You obviously do not want to do anything with those. They're assumed or anticipated denials. And then our sequestration, that CO253. A lot of people are still confused about this reduction in federal payments. It is a part of the federal government applying a reduction to the federal claims. Almost think of it like a tax, right? It's something that we have to take. So you are making sure that that's written off. There's nothing that you can do about the CO253s. Okay. So those three denials are just ones that I wanted to give examples of to you guys that might be brand new, because we've had people ask questions about those in the past. All right. So let's talk a little bit about our denials that we know we're going to be taking action on. Ones that we receive that we know for a fact are going to result in us doing something else. What that something else is will likely depend upon the remark code that's present and your specialty, right? If you're a surgical practice and you did not submit operative reports and you receive a CO16 denial, you probably have a comment code that says the operative report was not present. However, you may not. But if you know a carrier that always sends a CO16, you've learned based on past experience with that carrier that they always send a CO16 because you forgot to file the operative report, then you know what the next best step to take is, okay? So your CO50s are non-covered services that are deemed not a medical necessity, okay? CO50, the claims are saying these are non-covered services and they're being deemed not a medical necessity. When we have a question of medical necessity, in all instances, the next best step is to request or file medical records with the insurance company for an appeal, all right? Unless it is true. And I say that because so many people will do this thing where they want to go out and they want to fight and they want to do, but they don't even know what they're fighting for. This is where I would suggest that you, if you are a coder yourself or you have a coder at your disposal, you need to have that coder scan the documentation against what was filed on the claim, because oftentimes you are missing a diagnosis code that was supposed to be present, or in a particular scenario for your specialty, you are not allowed to bill a particular service for reimbursement. All right. When I say that, I'm really trying to I'm blanking on a good example and I should have written that down. But if you have a specialty that says that you are not able to provide a particular type of service in conjunction, so thinking like bundling, right? You aren't allowed to provide a particular type of service in conjunction with another service, right? For the same part of the body, right? If you have that kind of denial, sometimes we will see something like a CO 50 because they're saying this isn't necessary. You guys are creating this additional claim and now it's an administrative burden to the insurance company. You need to write it off. That's essentially what they're saying. Now, a coder in some cases can tell you if the documentation supports what was billed. However, you have to then consult what the contract says, because there are also, this is the problem with coders that don't have a lot of payer specific experience. If they are not familiar with the policies of the insurance carrier, they will not be able to give you enough information to help you decide whether this particular denial is appealable, okay? This topic can be quite expansive because your specialty is going to drive where I go next. So I have trouble having this conversation without taking you guys down a certain path with me of a specialty, and I don't want to close out those who are in different specialties. So I'm going to continue this kind of more broad stroke conversation and hope that you guys can make use of it. So please feel free to weigh in on things that you think has worked for you. I would love to hear that. But when we know that we have non-covered services for medical necessity, if you find that medical necessity was present or was proven in the documentation, or you have, sometimes they file a CO 50 because the primary care provider did not provide a referral for the service. That sometimes does happen. You can see if they picked the wrong primary adjustment code by looking at the remark code as well, and just determining whether or not it's as a result of them not having the referral. So this is the concern with some of our claim adjustment reason codes. Is sometimes the softwares, this is the insurance company's processing or adjudication tools, don't apply the proper claim adjustment reason codes. And when that happens, it confuses us and we think, oh, medical notes, and we start sending medical notes. When we need to look at those remark codes, we might find that, oops, they put this code that said medical necessity, but really it was because the authorization or the referral wasn't present, okay? So I really hope I've beaten that into your hearts, your minds today, because I really want you guys to understand, if you have not paid attention to your remark codes, you're probably missing out on the majority of the support that you can leverage to be able to help decide where to go and to resolve your claim denials. All right. So CO16, we talked about, the same thing goes there. This is a very common denial. CO16 is like people sending messages that are like, oh, CO16s, I don't know what to do. They're just all, it is going to boil back down to your remark codes, and then you becoming familiar with your payer's guidelines and your specialty, because there are some instances where you might have to have a particular field completed. And I will kind of explain this in a very broad stroke. You might have to have a particular diagnosis code for a specialty, right? If you're in a specialty that says we must have this primary code to be able to support the need for X service, that primary diagnosis code needs to be there on the claim first in box A, or at least linked as a primary code that's linked to the service that you're billed, right on the line item. So diagnosis pointing to that service itself. Okay. The other things that sometimes happen is with Medicare, a lot of Medicare claims with specialists have very specific requirements on boxes that we may not ever touch in other specialties or with other payers. So it's important to know what the rules are for those claims. And here's the deal. Medicare actually does a pretty phenomenal job on their education side. So if you visit the CMS website and look for your specialty's guidelines, I guarantee you they are going to spell out for you what is required. And when I say CMS website, you also want to check your local Medicare administrative contractor or your local MAC, right? Which is the company that you are filing with, that is going to also apply their own LCDs or their local coverage determinations. If you look at all of that information and apply it to your unique specialty, it will help you understand whether or not you are missing something from a claim. All right. Other thing I'd like to suggest, my folks who are brand new in practices, if you have not looked at previously filed claims that were paid, you are missing out on an opportunity, because you need to understand what changed. If you're brand new and you're the one who's creating these claims and filing these claims now, right? You're the one who is managing the billing now, but there was your predecessor, you didn't overlap with them and you never had a chance to be trained by them. You can still look at what they did. You have access to the system. You can see the past claims. And I literally mean look at the claims. If you see the claim was paid for this patient with said insurance company, you want to review that claim and see what could be different from this claim that got paid to this claim that got denied. Not saying that you want to go out in there and just go change a claim and fiddle with it. No, you want to have an understanding of perhaps something procedurally has changed. Maybe along with you joining the practice, a new provider joined the practice, and that provider is not using the right diagnosis codes or the right procedure codes, right? Maybe the insurance company requires a particular HCPCS code in lieu of a CPT code, right? Or maybe it requires a particular modifier be used instead of a typical, so a modifier that indicates right and left, RT-LT, instead of a typical modifier that might be used to separate or to indicate that this particular claim is allowed to be billed separate or was unbundled, okay? So it's important for you to know what are the little nuances and the differences that might have changed. If you're a brand new practice, you might have some more time researching with your carriers, trying to match that information with your coders as well, or getting some coding advice that has to be matched with the carriers. I have to continue to say this, reiterate this, because a lot of coders learn from coding textbooks, coding guidelines alone, and do not know your unique carrier's guidelines. And it's not a common thing that they're required to know both, but it is helpful when you have someone that knows both. Okay, let me quickly look at the comments because I have something blocking my screen. So, okay, let's see. Hey, yes. Amy says, yes, check your NCDs, NDCs and LCDs. That's right. And you want to pop that in the chat there. Amy, would you see if you could find an example like site maybe from one of the local carriers, or like spell it out for them? Those actually, I think on the Medicare website, CMS website, it has a section that says in DCs and LCDs to break it down. I think so. That's amazing. So, this is so sweet. Thank you so much, Local 11. That is so kind of you. Thank you for that. What do they call that? This is like a super chat thing. Thank you for that tip. That's amazing. I'm so happy that you are learning on the fly. That's amazing. So let me know where you need more help. I actually know a lot about PT, so I could make more videos PT related if you need them. All right, my friends. So, and Amy's going to hopefully look in there and find us some in DC and LCDs, because if you guys want to kind of get a sense of what that looks like, I think it would help you quite a bit. All right. Okay, so so we talked a lot about our CO16 and our CO50. Let's briefly touch on a CO17. I'm giggling a little bit because this is one of my favorite. Requested information was not provided, or insufficient, or incomplete is what CO17 says. And when they choose to put these COs that have the contract adjustment codes that have such vague language, I'm going to always remind you guys to look at the Remark codes, because a CO 17 could very well be something simple. Requested information was not provided, or insufficient, or incomplete. It could mean that you are missing something vital on the claim form that's required. So as we talked about, something, maybe the diagnosis code was missing, like things that maybe your system isn't properly checking, right? And you possibly are supposed to file a referral number or an authorization number on your claim form that's not present. All right. Even though they have other codes out there that say authorization is not present, sometimes, not sometimes, many times, these carriers pick the wrong code. So again, if there's a Remark code, look at that. It could help. I say the Remark codes a lot because there are so many companies, and all of my years in working with big denial teams, so many companies have this knee-jerk response to pick up the phone, like big denial teams that just work denials, and they are on the phone getting information that is already on a remittance, that already says on the remittance exactly what is wrong with the claim. So I'm going to keep reiterating to look at your Remark codes, because something like a vague requested information was not provided or insufficient could just be that you need to take the steps that are required for your specialty, making sure your authorization is present, making sure that you have a proper date of birth for a patient that's a child. Like, I know it sounds strange, but sometimes they link the wrong information on those denial codes. All right, sorry, I keep clicking on the wrong thing. Okay, so the next is CO19. This is a very easy fix, my CO19ers. This is a work-related injury or illness, thus is the responsibility of a workers' compensation carrier. This says CO. This goes back to what I had said to you before about making sure your systems are set up correctly. It says CO, which says contract obligation. If your software is set up to write this off, you will not know that you were not paid properly for that service until someone does a deeper audit to see that the whole visit was written off. CO19 just means that patient maybe didn't give us the proper billing information, or didn't mention that they had this work-related injury, and we need to get the workers' compensation information. So in this instance, we could go back to our patient to try to obtain that information and hopefully get those claims refiled with the proper carrier. So yes, the claims would get written off by that carrier that was billed improperly, but you want to refile the claim to the correct carrier, okay? All right, so CO29. CO29, the claim filing limit has expired, or the time limit has expired. So when it says time limit for filing has expired, is typically a blanketed denial that says that you didn't send that claim in time. You didn't send that claim quick enough for the insurance company to consider it. All right. Just a note. If you are not filing your claims fast enough and your shortest, timely filing limitation for your carriers is like 90 days, then you got to go back to these previous videos that we've been doing because you're missing something important in your patient's workflow. When they're first getting started, likely, or when things are first getting set up for billing, there's something that is broken. All right. And a lot of these denials, we'll talk about this a lot in denial management. These denials are great for illuminating problems that are intrinsic that need to be fixed, things that are at their root causing you these denials that need to be fixed at the root. You have to go back to the root cause and try to remedy it. Otherwise, you're going to keep having these types of denials. CO29s, whenever you see a lot of CO29s and you're new to a practice, you right away need to know that something is probably broken on the front end of the revenue cycle. Before the claim is even getting out the door, somewhere it's getting trapped, it's getting stuck, okay? And us as billing companies, we struggle with CO29s because it's our job to find them, but we sometimes can't, and it's hard to prevent them. We can't always prevent them. And here's the deal: is it's important that we take responsibility for the need to continue to educate and inform the front end when they're missing steps. All right, our patients that are coming in as reactivations or reactivating old patients, if the front end is not confirming the patient's insurance, and we already have an insurance on file, and you file that claim and then you refile that claim and then you correct something and you think, oh, it's just because the date of the patient's name was Tom and it's really Thomas, like you're correcting all these arbitrary things. When you finally get your denial from said insurance company, let's say it was Cigna, you get that from Cigna and they're like, oh, we got your claim. No, this patient's coverage is no longer valid, right? You're like, oh, shoot. And then you look back and you're like, oh, this patient hadn't been in for a big gap of time. Let me reach out to the patient and see if they have a different insurance company. You call the patient, like, oh, yeah, I have United Healthcare. Oh, God, United, 90-day timely filing. All right. So we say United Healthcare, or like, okay, great, send me the information. Now, Cigna situation for you to get that claim resent to insurance just to get the confirmation that they didn't even have coverage with Cigna anymore took you 4 months to figure that out. And now the patient gave you United Healthcare information and you're like, ooh, let me just put it in and send. Maybe they won't notice. The hope and pray method. They're going to notice because it's programmed in their system. They're going to notice, and they deny for CO29. What can you do? You can, in most cases, send a proof that you filed to the incorrect payer. You filed to Cigna because the patient provided you with that information, and then you found out it was supposed to be filed to United. Not every carrier approves these types of denials, approve these types of reconsiderations, meaning you've asked them to reconsider what they processed. But there are a lot of companies that do. So be prepared to still use your claim acceptance report from the primary or the other company that you build. So in my example, Cigna, I would use that claim acceptance report as proof of timely filing and file a reconsideration explaining the scenario. Don't just say, oh, the claim was filed in time and what. They're going to be like, no, it wasn't. That's not us. Like, you got to explain why you sent what you're sending and let them know that, it was our intention. However, our patient came back and let us know that we had the wrong information down the road. Now, the truth is this. Administratively, it is your responsibility to have the workflow right. When your patient comes in, you should be asking for that card and comparing it against what you have. So don't expect them to just kind of be like, oh, no big deal. We understand every time. You have to fix what's broken on the front. Okay. You have to fix it. Something wrong with what's going on in the front end. All right. Let's see. I love this. Yeah. Oh, yeah. This is yay, awesome. That's funny. Guilty of that one. Yeah, there's so many of us that are. There's so many of us that are. And then Amy's sharing a link. And as that, Amy, is that the link for the NDCs and LDCs? I just want to make sure that people have an understanding of what link that is out there, so that they don't think that you're just putting out a random link that might get them some ickiness for their computer. By the way, Amy's on my team as well now. Welcome, Amy, to the team. So that's why I'm talking to her so casually. I trust the link that she would put out there, just so that you guys know that. All right, so here we go. Patient type of denials. And I will say that in air quotes, because when we look at the way that the claim is being processed, there's a lot of practices out there that do this thing that they just drop the statement to patient. There's a lot going on here. You now have potential that you won't ever catch the denial that could be fixed easily in time. There's also this thing that you're now upsetting your relationship with your patient, which, no one likes that you would just knee jerk to send them a bill. Nobody likes that. All right. And then you have the potential that you will lose. Did I say that at the beginning? Yeah. You lose track of your denial, and you have the potential that you won't even notice that this denial came in the first place, right? I guess it's like a reiteration of the first one. There was a third, and it's just out of my head right now. But essentially, there are PRs that come in. PRs are those patient responsibility denials that you could, on your own, without patient's involvement, remedy. And I say that kind of with a little bit of fine print, that it really depends upon your workflow, right? If you properly have scanned those cards in, but nobody updated the information, or you are billing a patient's Medicare policy, little bonus, you can actually check Medicare records and get the patient's updated information or their new supplemental and all of that stuff without having a copy of your patient's information. If you had their original Medicare number and you now need to know what their Medicare Advantage plan is, or that replacement plan, what plan is replacing the Medicare coverage, you can get all of that through the Medicare resources online. All right. So you don't really need to have a whole lot of interfacing with your patients. Okay. So try not to knee jerk. Oh, I'm sorry. The last thing that you're doing when you're is that you are incurring the expense to send them these statements. You're wasting money. Like, why? There's so many people that have these systems that just automatically drop it to patient, and the patients just get bills like clockwork, and every single one of them gets returned. And then, they're escalating them to collections or whatever. Like, no one cares that you're sending them collections for $75. Like, nobody cares about that. All right. I'm going to keep saying that because it's real. Like, there are so many companies out there that will lend patients money for all kinds of things with medical debt, because we're in such a state in our country where medical debt is just a thing. All right. And we all deal with it, right? We've all dealt with it. And so everyone understands that if you explain it in a letter, that no big deal. Okay, so the types of denials that we have that are PRs that are most common that you guys can resolve are your PR26s, which is the expenses incurred prior to coverage. Your PR27, which is expenses incurred after coverage was terminated. Basically, both of those things say that the patient didn't have any coverage with that carrier. So PR26 says that you billed the claim to an insurance company before it came into effect. So the data service happened before the claim, before the insurance carrier's coverage was in effect. Okay. The PR27 says the opposite, right? You billed the claim after the data, after the gracious, after the coverage terminated, your data service took place. Okay. So they're just the reverse, but saying the same thing, which means that the patient did not have coverage. When you get those PRs, 26 or 27, you are going to want to look to see if your patient provided an insurance card at that time of service that perhaps someone just did not update. It happens so much because we spend a lot of time, and even on this channel, we've talked a lot about your data capture for your new patients, but we haven't really spoken a whole lot about the reactivated patients. What about the people that came back after not being there for months or even sometimes years? What is your workflow for those people, and who is going to be the one to kind of make the updates to those patients, right? We need to make sure that we potentially are doing the same thing. We looked at the new patient log. You're doing the same thing for people that are coming in with changes of insurance, that you're making sure that the verifications or whatever needs to happen with your specialty are done, and then that you are updating their patients and that the claims are going out and getting paid, right? So that was what we did with our new patient log. You can do the same thing for your reactivated patients or your patients that are coming back in after a period with new insurance, okay? This is very important because we're about to come into a new year. We will have a whole section of discussions about how to make this new year a really strong one for my people who struggle with these kind of new year resets. There's a lot to be done for the new year, and a lot of people don't have a process for what to do, what to say even to your patients as they come in at the start of the new year. You have to implement a script for that new year. Otherwise, you're just going to be losing money left and right. Okay. All right. So PR28 coverage, not in effect at the time of service that the service was provided. I'm sorry, I should have mentioned that. Those three are the same. 26, 27, and 28 all just mean the patient did not have coverage. They did at some point, but they don't have coverage now. All right. PR31 is patient cannot be identified as our insured. Now, I will say this, PR31 could mean that, yes, you billed the wrong insurance, or it could mean that something is wrong with the patient's demographic information. Maybe the date of birth is wrong. Maybe the ID is a little off. Maybe you spelled their name instead of putting Tom or Thomas, you put Tom, and the insurance company is not matching that patient's identity. Okay. Doesn't mean that the patient should be receiving a bill, because it could be something that you could correct. It means that it could mean that you have something that you've done with your initial data entry or data capture when you grab that information to create your claim that you don't have correct. Okay. Same is true for PR32. It could be a similar scenario as PR31, but it also could mean that you potentially have a patient situation. This one, I'm sorry, says our records indicate this patient is not an eligible dependent. It could mean that you obtained the parents' billing information. Like, let's say the patient came into a family medicine practice and patient mom came in with child, and you thought insurance was the same for child and mom, but no, child has insurance with dad's company and you billed mom's insurance company. Okay. So it's another way for them to say that this particular patient does not have coverage, but your scenario could be unique, that you might have dad as a patient as well. And you could very well just swap out the information and resubmit it, or you're calling patient to try to get, or reaching out to the patient to try to get that remedied. All right. This is all stuff when it comes to patient that could be fixed if you follow those recommendations from the last videos, because they're all things that are going to get you eligibility checks done before the visits take place, done before the patients leave the office. That's the key part, is you need to get all this stuff kind of ducks in a row before your patient walks out the door, because your likelihood of being able to get in touch with them, or especially if you don't have like a text messaging ability within your system, you probably won't get in touch with your patients. I know it sounds bad, but so many people do not pick up their phones. And if you have to be able to communicate with them through a portal or through some sort of electronic means securely, right, to just ask them to call you, and that's possible with a lot of text messaging interfaces or patient portals, it's harder when you're trying to call them and you're calling from the billing department from an 800 number or something like that. All right. So yes. All right. Took a little longer than I expected. It always does. All right. So here's what I want to know. I want to know from you guys, was that helpful? did you have other questions? So I like it. Okay, cool. Yay. All right, awesome. Amy says that yes, that's an example of one, and that's where you can search for any. I love it. Thank you for sharing that. Awesome. All right, so I want to know, was it helpful, this kind of very high level discussion of denials? When we get back together next time, I'm going to group together some denial types and we're going to look at them on the screen. I try not to do too much screen share here when we are on these lives, because you guys don't talk as much when I do screen share, but I think it's easier at certain things like this discussion. So next time I will pop some of these codes on the screen and we'll talk through the types of denials and things that I'll group together. So ones that we know for sure are patient related, or ones that we know for sure are insurance coverage related or pre-certification related. So you understand that even though it says such blanketed language, it really means that an authorization is missing, right? So, and once more, my scenario might be different than your scenario, right? But when I see a CO11, right, a CO11, I'm almost always thinking something is wrong with the coding, right? Something is wrong with the modifier potentially, or a procedure code that's being used, right? So those general rules will still be very relevant for you. And I want to know what general rules you see in yours. I didn't talk about duplicate claims because that's like general for everything and everybody. And we could talk about the ways to save you guys from getting those duplicate denials. So I love it. Yay. Love that. Thank you. Hey, Carmen, good to see you. Very helpful. Thank you. Local 11, thank you so much. Yay. Yeah, I'm happy you caught it live too. Thanks so much again for that super chat. And my friends who are here for the first time or just joined, I want to just quickly mention again, Nicole just pops it in here. All of our courses, what you get here on YouTube is great. I hope it gets you what you need when you're looking for certain things. But we do have organized courses that are already out, and a lot on the docket to be released in these next couple of months. And you will want to take a look at that to kind of get a sense for whether or not there's something out there for you, because we have our Black Friday sales happening right now. So our courses, everything on that site is 40% off right now, which means that you will receive 40% off of all of the courses that are for sale or the ones that are in pre-order. And if you are looking to commit to taking Mastering Medical Billing in February, you can save 40%, right? If you're wanting to take the next CPB readiness coaching program with me, you can save 40%. And then I'm also going to do a little nudge here for you guys. Oh, let me see. Quick question. If a patient has Medicare, oh, I love this. This is a great question. If a patient has Medicare and TRICARE for, okay, so no, it is not. Let's say TRICARE for life, is it always secondary? Yes, that here Medicare is typically going to be primary. TRICARE for life. So I'm just referring back to the fact that you are PT. You have to be registered fully with Medicare and TRICARE for life, and a lot of the TRICARE plans, the TRICARE plans don't cover a lot for PT. So you're probably going to see a lot of Medicare that drops to secondary anyway. I mean, that drops the claim over to crossover, that gets denied. So I hope that helps. But yes, you're going to see Medicare stay as primary. In a lot of instances, you're going to have Medicare as primary. It's very rarely a secondary, unless the patient is still working. All right. Cool. Linda, yay. I'm glad you liked that. I'm glad you liked it. Okay. So real quick, I wanted to just quickly mention one last little thing. So I told you guys already that we've got memberships on the channel. We have another level of memberships that is going to start in January. And then we have something else that I really am excited about, because my time and energy is shifting, because I want to give more to you guys on this channel, to the content and courses that we're creating, and to our folks that are opening billing companies, are serving clients and wanting to pursue independent business ownership as a billing company. All right. So I know I get this question a ton. So I know a lot of you are going to be like, yay, because we get this a lot. Like, when am I going to be ready to help billing company? And we've done some things here and there, but I've just been busy with other things. And now that's kind of being alleviated, where I now have a lot more focus and attention and energy for us to work together so I can help you guys with your billing company. I forget the word for it, your dream, your billing company dream. All right, so here's what I'm thinking I want you guys to do. If you are interested in this, do me a favor, pop over to the community page on YouTube and vote in the poll that's there. Let me know if you're interested in that type of content on the channel or not. One thing to also just make note of is we have 2 new things happening with billing company owners. That is a separate YouTube, a separate yes, a separate YouTube live, but also a separate Facebook group as well. And I'm going to give you guys a little secret, little nugget is we have something called the Inner Circle that's going to be releasing as well. And that is for the folks that are wanting to work more closely with us. Our inner circle is going to be folks that are wanting to create, grow, and or a scale an established billing company. When you are wanting to kind of have your hand held and have a community of people around you. So the Inner Circle is for our billing company. We're calling it a billing company incubator. It's going into beta. So as a part of being in the Inner Circle beta, you guys will get a lot of really cool things. We'll go over this in a totally separate chat, but we'll get a lot of really cool things, and you're going to get it at like a fraction of the cost because you guys are going to be beta testers for me. So you're going to help me curate a program that you would want everyone to take that wants to start their billing company. All right. And my friends, you guys, if you've not ever worked with a coach before on business or doing anything like this is the thing to do if you want to be successful, because we all need accountability. If you're new here and you don't know what I'm talking about, I've had my billing company for 20 years now, this month, actually, which is crazy. And so I have a little bit of knowledge and experience, and I learned very early about working with a business coach. I did it more for marketing, less around the specialty specific for, in healthcare. But once I started to get into business, like more general business or business service oriented coaching, it completely changed the way that I do business. And because of that, and because of that access that I have to all of that, those years of coaching and support and all of that, I want to give that back to you guys, because there's so many billing companies out there and it doesn't matter what size you are. It could just be you and you want to have three clients that you serve, and you as an independent sole proprietor business, or you could have an entire team of people, right? It doesn't matter. You still want to apply the same approach to how you treat this, and that is as a business. Okay. So I'm excited to share that with you guys. So keep an eye out for information on the Inner Circle. And then we're also going to be starting to do some lives related to billing company owners. That'll start in January. And yay, I'm excited too. Yay, Carmen. Thank you for that. Cool. All right, my friends. Nicole wants to drop that Facebook link. So go ahead and drop that Facebook link in there. That's for the billing company owners Facebook link. If you know that you are interested in that content, you can join that. Also, you can pop on that community page and weigh in on the poll that's happening right there, and let us know whether you're interested in that type of content, and that will just help us direct the content for the channel. Cool. All right, my friends, listen, thank you so much for being here. Thank you for your input, your energy. It's such an honor to guide you guys on this journey in this crazy fun world of healthcare. I will see you guys next week. We will announce when we're doing the live next week. It won't be Thursday because it's Thanksgiving, but we will be doing a live, and it's going to be me talking to you guys about how grateful I am. And I'm excited to have that chat with you, and I hope that you guys have lots of things to share as well. And we'll see you guys in the next video. Take care, my friends. Thank you, guys. Bye, Carmen. There's the Facebook.